next speaker will broaden the topic, and it's Audra Stinchcomb, Professor of Pharmaceutical Sciences at the University of Maryland in Baltimore. And Dr. Stinchcomb will talk to us about IVPT studies with topical and transdermal products.
I want to thank all the previous speakers. I think this is a wonderful 3-day event that's going on. And, you know, I'm just going to reiterate, it's true, actually. It was Dr. Jim Polly who asked me yesterday, Audra, I know that IVPT's been going on a long time. Why, haven't you guys gotten busy and standardized it for regulatory science? And I think we've heard great descriptions of why that is. And so we're going to hopefully move forward more quickly. And a lot of that progress is because of the orchestrator of this 3-day meeting, Dr. Sam Ronnie, who I've had the pleasure of working with for the last 7 years, and his group of experts that the IVPT methods. We're gathering the data that Dr. Bashaw talked about, and we are trying to move forward with standardized methods. And the FDA has been hard at work working on the statistical parts and the other parts that you'll hear about over the next 3 days. Before I start, I also want to make sure to thank the people behind the scenes here, the UMB team, especially Dr. Jim Polly, Dana Hommel, and Paige Zambrana for being very good at IT and becoming WebEx experts. Okay, so let me just get started on what I'm supposed to talk about. This is just my disclaimer. I don't work for the FDA. I work for the University of Maryland, and the other potential conflict is I have a company that develops and tests complex drug products. So our preference over the last 30 years has been the inline diffusion cells. And you heard Dr. Yang talk about all the different types of systems that are going to be evaluated, and that's fantastic because different groups like to use different systems, and if they all have tests that are discriminating, that's wonderful. So we have liked this inline diffusion system for many of the reasons that she talked about, the automation and the chance to renew the receiver fluid. You can change the rate of the receiver fluid to create sink conditions. If you need a higher flow rate, you can do that for some compounds that aren't as soluble, and you can add things to the receiver fluid as well to increase the solubility of the drug. I think there's a very good article, actually set of articles by Bob Bernal, I think it was in the 80s or 90s, where he looked at all types of different membranes, different thicknesses and types of skin, and looked at different receiver fluid enhancers. And that was certainly a place where we started 30 years ago, looking at that reference where he talks about what kind of receiver additives can damage the stratum corneum, but it does depend on the type of skin you're using and the thickness of that skin. So here's what we do. We take tummy tuck surgery skin and we dermatome that to a split thickness. We use the inline Permagear system. And then for us, we use the transepidermal water loss is what we've used for years to make sure the integrity of our skin sample is good before we actually dose the skin. And then we put the formulation on top of the skin very carefully. So this is something that Dr. Ronnie mentioned in his presentation. It really makes a big difference how you apply this dose. And so if we have less viscous solution type formulations, we'll use a positive displacement pipette. But in the case of most of these topical products, semi-solids, we're using an inverted HPLC vial, which is nice because you can pre-weigh the vial, add the dose, weigh that, know exactly what it is, and after you dose the skin, you weigh that again and you know exactly how much you put on the skin. So this is a great enhancement to these types of studies. Most of the work that we do is based on in vitro and vivo correlation in our research over the last 30 years. And so that's what I'm going to talk somewhat about, but I think Dr. Ronnie and everyone else made this point, that this is, IVIVC is important, and for research and different things, you should have IVIVC depending on what you're doing. But for using IVPT in bioequivalent studies, for example, that might not necessarily be the case. And so if you can get a discriminating IVPT study on human skin, then that is really a good surrogate for these types of situations. One thing that we've looked at in these studies is the effect of heat on the absorption, and we were able to look at that in IVPT and in humans. So our general approach has been to do these initial exploratory IVPT studies to see what kinds of products or applications would give us increased absorption with heat, and that would help us design a human study that would give us the answers that we needed in the pharmacokinetic data. And then from there, we would gather some very carefully controlled, harmonized IVPT studies so that we could then go on to look at the in vitro and vivo correlation. And so one of the important things about the human studies for IVIVC is if you have too much variability, your IVIVC isn't worth much. And so it's important to try to control as much of the variability as you can in the human studies when your goal is IVIVC especially. So we've looked at a range of products with the FDA over the last 7 years or so, and this is what we've looked at. The first, not the last compound in the box, is oxybenzone, one of the sunscreen filters. We have investigated that on our own, but we have looked at all these different compounds in IVPT and most of them in humans to see what kind of information we can get in the IVPT and in the human studies. And we've had a great variety of physicochemical properties and molecular weights within reason, because large molecules don't really go through the skin very quickly, so we don't study that. So here's the first study that Dr. Ronnie mentioned, and this is where we got our first good IVIVC relationship with the human study that we did. So we looked at the effect of heat on these different nicotine patches. These are not bioequivalent, by the way. And we were trying to see if we could see significant differences in the heat effect on these different types of patches. And we did that in humans, and we did that in 10 volunteers with the help, this is Dr. Sushin's thesis project when she was with us in Maryland, and now she is working at the FDA. But we looked at our differences in the humans, and then we got our IVPT data, and we were able to get very good predictions from the IVPT data, and based on the human clearance values of nicotine, then we were able to come up with that the IVPT was predicting what happens with the nicotine heat effect in the humans very well. And we picked, I think, kind of a low-hanging fruit initially. Nicotine, of course, as you know, is one of the most permeable, perfect property skin penetrants, and so it permeates very rapidly, and the IVIVC worked out very excellent. The next product that we looked at were fentanyl patches. So we looked at Duragesic and 2 generics. We did that again in humans with the heat effect and in early and late heat to see what that did to the drug load, and did that change something later on in the wear time. And what we found was that our IVPT data did not predict the human situation as well. And that's what Dr. Maybach was alluding to. You know, you have a drug depot in the skin, and so that might be something that you're not going to pick up in IVPT, and so that wouldn't be expected. You don't have subcutaneous tissue in IVPT, but that doesn't necessarily matter when we're trying to look for a test that is discriminating the results from different patches with a heat effect. So what we would primarily be interested in is, would a generic patch have a very different heat effect profile from a brand name patch? And so we had still decent IVIVC, but not as perfect as the nicotine. We've also looked at buprenorphine, and this study was done by Sharon Thomas, who graduated recently and is also working at the FDA. So we looked at some clinical data that was available for Butrans on the FDA website, and there was a heat effect study there. So Sharon then looked at making a harmonized IVPT method, and she got very good correlation in the IVPT study of what was happening in the human study as well. So I think for heat effect studies, IVPT is definitely a potential test that can be used. Here is another study by Sharon Thomas, and we looked at heat effects in the lidocaine patches this time. This was interesting as well because we have this hydrogel patch that is the brand name product, and then we have the generic that is not a hydrogel patch. It's a polyisobutylene, so more of a controlled release system. And you can see that in the profiles. These are the flux profiles from IVPT. If you look at what happens in no heat with the hydrogel product versus when you apply heat to a hydrogel, which is not technically a controlled release system designed for systemic delivery, this lidocaine patch is really for treatment of subcutaneous tissues and not for systemic delivery of lidocaine. You see a much higher variability from this hydrogel system when you apply heat, because that's not how it was intended to be used. And so there's variability when you apply the heat. But when you use one of our standard transdermal adhesives, polyisobutylene, you can see that we have much less variability when we apply the heat, but we still have a similar extent of the heat effect in that generic product. So, and you can see that also in this Jmax enhancement ratio that we look at. So we're comparing right before we add the heat, what the level is, and then what the level is after the heat is applied. And you have this big increase with the heat effect in the Jmax. And so we see, especially in that hydrogel patch, a big variation you can see in the Jmax enhancement, and not as big of a variation in the generic, but still there is a significant heat effect in that generic product. Sharon Thomas also looked at Diclofenac products in vitro and in humans, and we saw some really great information from this product. So what I like about the Diclofenac products as a researcher is it gives me this wide variety of formulations to study. So we have this patch system, we have a solution with a lot of DMSO, we have a 1% gel that's designed to give you more permeation, and then we have this Solaris formulation, the 3% gel, that's really designed to treat and prevent transition to skin cancer and actinic keratoses. And so in order to concentrate the diclofenac more at the surface of the skin, there is a hyaluronate sodium in that formulation. And so when Dr. Thomas looked at this in vitro, the IVPT profiles also reflect the differences in those products. So you see our patch system, and this just happens to be with and without heat. So we see an increase in the permeation with the patch product on the top left. Then on the right, we have the solution with the DMSO in it, and we see a lot more variability. We have a lot of solvent that's increasing the delivery. And when we apply heat, we see a significant effect there in the permeation. So the most significant heat effect of all these diclofenac products. And with the 1% gel, that's really for treatment of muscle and joint pain, you see an increase in the permeation when you apply the heat. But with that 3% gel that has the hyaluronic acid formulation excipient in it, you see less absorption through the skin and less of a heat effect with the addition of that hyaluronic acid. So that made a very nice formulation comparison study. We have also Xinxiao Zhang, who is going to graduate soon. She has worked on the metronidazole project. She compared a brand name gel and a generic gel to a generic cream and got good differentiation in this data, similar to what you saw in Dr. Ronnie's other data. So for the gel, generic gel product, we have overlap with the brand name gel product. And for the generic cream, we see something similar to that we see with a formulation that doesn't evaporate. And so there's still a significant amount of excipient on the surface of the skin, the different oils and things that are in the cream formulation, and you have delivery that continues for 24 hours, and you don't see the peak like you did with the gel product. So after we'd worked on all these other projects, we decided that sunscreens were something that was a very important, obviously, public health issue. And after talking with Dr. Bashaw for several years, we decided to embark on a sunscreen product in vitro in vivo correlation study. And so our main interest initially, before we knew much about what was going to happen with these products, is to try to standardize the application method for all these different types of products. Sunscreens are great because they give us a good research tool. We look at foams, different types of sprays, gels, creams, solid sticks. So we have all sorts of different things to compare. And it created a great product database for us to look at for the IVIVC. And this project is Paige Zambrana's thesis project. She is also graduating soon. So she looked at initially some of the single dose studies that we typically see people do, and we saw differences in the permeation profiles depending on which formulation we used, and then we saw a different type of profile from the spray products. Here for these two spray products, we saw overlap of the flux profile in IVPT, and we saw different peak times. So we know that the formulations are definitely influencing the increase or changes in the absorption. For our purposes, we've used oxybenzone as the model sunscreen component, and we picked that largely because it was the compound that has the most absorption in the clinical studies, and so we thought that would be the easiest thing to look at initially. One thing that we've also been interested in for a long time, besides the single dose studies, is what happens when we do multiple dosing. So especially in terms of a toxicology study like sunscreen studies are, we would like to see what the maximum absorption might be. And so we used multiple doses of the sunscreens. We picked a dose of every 80 minutes because that is what is on the sunscreen packaging, saying you should apply the sunscreen every 80 minutes if you are exposed to water, for example. So we did 3 dose studies every 80 minutes and picked products with 6% oxybenzone and went on to do in vitro and human studies. So here is some of the data from these studies. So as Dr. Ronnie said, you want to be able to discriminate. So here we can discriminate between a single dose and reapplication. But as he said, it's not potentially going to be a linear increase. So we have an increase, like for the spray product, when we give 3 doses versus 1, but not as much of an increase as, for example, with some of the other products. And so when we compare these different products to each other, we have very different profiles depending on what the formulation is. And we also explored the effect of heat on the products and how that would affect absorption. And we chose 37 degrees Celsius as something that might be a typical beach temperature. And so we do see a heat effect on absorption for the products. And depending on the product, we see less of a heat effect, similar to what we saw for the prescription drug products. The other thing that's going to be talked about more during this meeting is what time points you choose. And so often in our initial studies, we'll start with some far apart spaced time points and then maybe increase to make sure that we're capturing all of the profile that we need to compare these formulations to each other. So here are the 4 products that we used. More of a cream emulsion, a water washable lotion, a solid stick, and a continuous spray, all with 6% oxybenzone. So Paige went ahead and did the IVPT studies on that, and we could see from our more oily cream product that we had much higher oxybenzone flux than we did for the oxybenzone from, for example, solid stick lotion, and the spray always seems to give us the lowest permeation, and we saw that from Dr. Yang's data as well. One thing that we wanted to do was do IVIVC, and so we didn't want to do a must study because, as Dr. Bashaw pointed out, that is a very long, expensive study. And so we wanted to create kind of a mini must study that could be easily done and not allow overnight stays in the clinic, which is very expensive here at the University Hospital. And so we wanted to create kind of a miniaturized version of a must study to give us some good PK data to see then if we could get IVIVC based on that data. I think the one thing that needs to be pointed out is that the sunscreen dosing is only 2 milligrams per centimeter squared. And what we're going to hear more about today for the drugs, often people are using 5 to 15 milligrams per centimeter squared. So there are some differences in optimizing your dosing for your different needs and your different types of products. One thing we also wanted to do here was decrease the variability for the human data. So we controlled humidity and temperature in this study. And so our clinic has some variable humidity and temperatures on different days. And we wanted to be able to compare all the data to each other, reduce some of the variability so we would be able to do some good IVIVC at the end of our clinical study. So we created this kind of small isolated environment where the subjects are treated. So in order to maintain the humidity and the temperature just where we applied the product to the volunteers, we created this 3D printed dome, and then we added heat control by attaching an infrared heating pad to the underside surface of that dome, and then we created humidity control with a humidifier that would automatically adjust itself to control the humidity inside of the dome. And here's what that looks like in the clinic. Subject can just lie down, work on their computer or whatever, and be comfortable during the study. And what we're doing then is only applying the formulation over the thighs on the human subjects, whereas in the must study, you're applying it to 75% of the body and doing that for multiple days. So initially, we were hoping that we would have enough significant absorption of the oxybenzone so that we could even do IVIVC. And according to our IVPT studies, we would, with that smaller surface area than what FDA had done. And so we were able to detect the oxybenzone just from that small application area. And this type of system can also be used to test other topical and transdermal compounds. We got very good skin temperature control with this method. So even when we removed the dome to do the second and third doses, we had very small blips in the temperature and humidity changes. And because humidity has such a huge influence on the evaporation rate of topical formulations, that can significantly change your absorption. So here is the human data that Paige got. So remember, we had started out with initially finding products that would give us the highest absorption rate. And so we have trends towards discrimination, but we don't have complete statistical discrimination yet. And maybe we don't need to. So for the creams, we see more variability with a product that stays on the surface of the skin longer, but the formulation excipients are still present over our 12 hours. And we see a trend towards the most absorption, as we saw in vitro. And with the solid stick and lotion, we see similar profiles. And then with the sprays, really that vehicle evaporates very rapidly, and your compound is delivered from the surface of the skin in a very well-controlled manner. So Paige went on to do level A IVIVC of this data. So she took the in vitro data from the IVPT study. She took the clearance of oxybenzone in humans, and she was able to predict the profiles from our mini-must human study to get a very good correlation with the IVPT and the mini-must study. So we really think we've got a good start on looking at a clinical test that's more abbreviated than other types of clinical studies for these methods and types of products. And we can then next go on to what happens if we remove the formulation from the surface of the skin. Can we see the decrease and other things like that? That would be more complicated now that we know how to standardize the application of all these different types of formulations. So I think, like Dr. Bashaw pointed out, we have this IVPT plan that we've been using, according to Dr. Maybach, for 80 years. So let's do this. Let's get it together as a regulatory test. And I really believe that this test is good and gives us very good in vitro and vivo correlation for many types of products. And that's kind of our ultimate goal for research. But this is not necessarily what we need to discriminate amongst different products for bioequivalence approval. So that is my point repeated. And I'd like to thank all the people that we've been working with over the years. Dr. Strasinger, we worked on patch strength studies, and Dr. Ronnie and Dr. Ghosh, we have worked with them for 7 years on many IVIVC and transdermal heat effect studies. And all the people that it takes to do clinical research, we have an entire clinical study team at the hospital. We have our mass spec team and our collaborators who worked with us for many years. And our Sunscreen funding comes from the University of Maryland, Baltimore Mass Spec Center, where we have done many assays for all types of compounds in plasma. And with that, I will end, and I guess it's time to go to our panel discussion.